labor, use of prostaglandin should be withheld, preferably in the previous scar. And myectomy due to increased risk of rupture. Patient with non-recurrent indication and chances of vaginal birth need to be counseled about associated risk indicating uterine rupture. Oxytocin use for augmentation of labor with paired cesarean is not associated with increased risk of rupture. So we all tell you induction in the previous cesarean section. I have told you there is a little increased risk of emergency cesarean section as well as increased risk of uterine rupture. So woman has to counsel judiciously. We have to use the method of induction. Now, induction of in diabetes pregnancy, we always remain that in the cases of well-controlled GDM, we have to terminate a pregnancy at 40 weeks. GDM with insulin treatment, 38 weeks. Over-diabetic, well-controlled with no other complication at 38 weeks completed. Uncontrolled diabetic whenever it is indicated. As it is in the preeclampsia, gestational hypertension, we have to induce at 40 weeks. Mild preeclampsia at 38 weeks, severe preeclampsia 34 weeks, and maternal and fetal complications immediately left. So what happens if next steps if induction does not work? If cervix remain closed, not prepared for labor, and it is not possible to rupture of membrane following a mechanical or hormonal approach, then you may be offered to stop the induction and try again after a break, the next day or later if appropriate, or alternative induction approach or cesarean delivery. So this was about the induction of labor, and the last slide about the prophylactic induction. What is this? It means risk reducing induction. In the past, induction of labor in low risk patient at 39 week was called elective. However, now a terminology changed to risk reducing induction, also called prophylactic induction or induction at 39 weeks. It leads to reduction in cesarean, reduction in other adverse neonatal and maternal outcome, reduction in macrosomia, in stillbirth, and ability to control the time of birth, which this could be important. Induction before 39 weeks, risk reducing induction should be avoided before 39 week of gestation, as their morbidity of birth before 37 week is well established and is also associated with greater neonatal mortality, morbidity, and healthcare utilization. So finally, general approach for the labor induction. If you are approaching, you have selected a case for induction of labor, you see the whether cervix is favorable or not. If yes, then begin the oxytocin and do AROM if it's feasible and safe. If it is yes, then AROM, continue oxytocin, provide routine intrapartum care, and until there is a vaginal birth, cesarean birth because of a standard intrapartum indication or because of failed induction. If the cases there is no, you start the oxytocin, ARM is not feasible and safe, then you continue the syntocin alone until ARM can be performed. Even ARM, if it is performed, then you continue the intrapartum care, but if it is still cannot be performed, then you have an option either Caesar birth for future failure to generate regular contractions and cervical changes after at least 24 hours of oxytocin administration, or if safe to delay delivery, then you discontinue oxytocin and repeat some process on another day. And the other thing, if cervix is not favorable and you have to induce, then definitely you can initiate a mechanical or pharmacological cervical ripening method. If it is favorable, then I have already told you do the oxytocin and with ARM. If cervix is not favorable, then definitely, as I have told you, that you can do the use of cervical ripening agent like dinoproston, and you can add with them some mechanical method, and again you can add also oxytocin also, and then as the cervix you find out the little cervix dilated or it is ripe, then you can use the ARM and safe to do so. So this was the approach for induction of labor, and counseling is always very important part, and you have to counseling checklist. Induction of labor is a medical intervention that will affect birth option and experience of birth process. Hormonal method of induction can cause hyperstimulation. Induced labor may be more painful than a spontaneous labor. Hospital stay may be longer than the spontaneous labor. The reason for induction being offered has to tell the woman when, where, and how induction could be carried out, has to tell the woman. Arrangement for support and pain relief. So all things has to be actually counseled to the woman before, so that they can be mentally prepared for the all consequences as well as for the process. And this is a consent you have to take before doing the induction of labor. So induction of labor, this is always the procedure. It is not a very simple thing. It is some judicial thing which we have to learn and practice properly to achieve maximum success and least complication. And it is definitely a mandatory step to reduce cesarean sections, which is emphasized maximum by all health associations all over the world. So thank you for this patience hearing.
Yes, thank you so much, Dr. Bharti. Before the chairpersons make some comments, I would like to interrupt here. Please allow me to welcome my mentors, advisors, respected Madam Jaideep Malhotra and Sir Narendra Malhotra. So I would like to welcome Dr. Narendra Malhotra, sir, who is the Managing Director of Rainbow Hospital, and sir has got so many accolades to his credit. All of you know him by his achievement, but I would say a multifaceted and multitasking personality, so inspiring for everybody. So we would like to have your blessings and words of inspiration from you, sir. Over to you, Dr. Narendra Malhotra, sir.
So very good evening to all of you. It's indeed a pleasure to be here on this wonderful webinar which has been organized on labor. And the newcomers, a great message. You have to learn obstetrics. Today, just after passing out MD, people are going for laparoscopic surgery, IVF. They don't want to do obstetrics. Obstetrics, you did MD or MS OB/GYN, and OB comes first. Unless you know how to deliver babies and induce labor or manage abortions, recurrent pregnancy losses, all that, you will never be able to do other super specialties. So my advice to the youngsters who are not willing to wake up in the night and sit with a laboring woman, please practice obstetrics for a few years before you choose to go into any of the 10 to 5 jobs. That is very important. A fantastic overview given by Dr. Bharti Maheshwari on induction of labor and its methods. This is what has to be taught. And we, in our time by Dr. Daftari, were taught programmed labor, where we used to program labor so they deliver, induce in the morning and they deliver by evening. So the nights are not there. And by previous night, you give a tablet at home, and then they come back in early labor and you induce or accelerate. So active management of labor has to be learned and practiced, and induction of labor is an art, and delivering babies is an art. So that is what we have to learn. Fantastic. Congratulations, Dr. Sneha Bhunyar, for organizing this wonderful, wonderful webinar. All the best to all of you for your future in Foxy. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir. May I invite Madam Jaideep Malhotra? I'm sure all of you know her, and there's no need for this, a busy slide, I would say. You just named the organization, and Madam has headed it. Such a illustrious personality. But apart from this CV, I would just say such a fantastic human being, very kind-hearted, always very broad-minded, a successful entrepreneur, and a very good, caring mother, and of course, a good family maker. Inspiration to almost everybody. Lots to learn from you, madam. We really want to listen to your precious words. Over to you, Madam Jaideep Malhotra.
Thank you so much, Sneha. I really, from the bottom of my heart, thank, because you always remember. And that's something which I really appreciate. And I really congratulate you for a wonderful webinar. I was just going through the content of the webinar. And if people would remember, in my year as Foxy president, we had concentrated so much on Adbhut Matratva. And this is all about Adbhut Matratva. And I would say in that year, we also had done the art and craft of vaginal delivery, because that is something which is a totally losing art. And I don't think we can progress any further if we lose this art. Very recently, there were people, who were trying to find out hospitals where nurses could be trained, where these hospitals had a fair number of vaginal deliveries. And I was absolutely shocked to know that they were having real challenges in finding hospitals where there were fair number of vaginal deliveries. So how are we going to train our postgraduates, our nurses, our support staff, if we are not really, delivering as many vaginally? And that's something which is big food for thought. And I would say there are so many professors here who are there in this webinar. There are so many teachers here. This is something which we should take it on a war footing. And Bharti, thank you so much for your wonderful lecture. I had the privilege of listening. And I really feel, as Naren was saying, when we were postgraduates, we were so awed by Dr. Daftari and Dr. Shyam Desai and their whole team. on programmed labor. And in fact, I invited Dr. Daftari for this particular the regional conference which we had in Udaipur on the art and craft of labor, because this was very, very important. And I would really feel that, please take it up in a big way and teach our youngsters, motivate, inspire them to look after our pregnant women to the best of their capabilities and abilities. We are really capable of much more than what we are really delivering. So that's why the patient's expectations are also more. And to prepare the patient mentally for a vaginal birth is also equally important. And I would say, please use the iMoms app. Tell your patients to, make use of it. It's a wonderful, wonderful app which will really help each and every one of us in preparing our patients mentally and physically for vaginal birth. Thank you so much for having me, and God bless you all. Keep on doing the good work.
Thank you.
Thank you, Jyoti.
Thank you
Thank you so much.
Of course, I do remember all this, and of course, the art and craft of vaginal delivery, I being the active part of it, demonstrating all the shoulder dystocia and various malpresentations and the difficult deliveries. I assure you that we go ahead and continue all these programs. Thank you so much for sparing your time, madam, and thank you so much for your valuable message as well. Thank you so much.
I would like Tamkeen Khan ma'am, our chairperson, to give her valuable comments on this on the topic of induction of labor, spoken so well by Dr. Bharti.
Thank you. Thank you so much, Dr. Sneha, for inviting me. And I had this opportunity of listening to Dr. Bharti, as usual, very evidence-based lecture. And she has covered such a vast topic very comprehensively, especially all the different situations and also the risks that are there. So just I would like to remind the postgraduates who are, listening, that unnecessary inductions are part of disrespectful care. It is not respectful care if you do an unnecessary induction. So please remember, it is one of the greatest success stories of modern obstetrics to be able to manipulate labor in that manner. But it is associated with lots and lots of risks. You have to monitor patients very, very carefully. Thank you so much.
Thank you.
And wishing all the best, Dr. Sneha.
Thank you so much. Thank you so much.
Thank you, Tamkeen Khan ma'am. And Manju Shukla ma'am's message had come that she had to attend an emergency, but she has sent her message that regarding it. Manju Verma ma'am, would you like to comment?
Madam,
I would like to say one word,
Yes, ma'am.
I must congratulate Bharti for giving us, जिसे कहते हैं कि एक पिटारा खोल दिया है उसने. So really congratulations for your such an elaborate lecture on such a vast subject. And here I would like to mention my postgraduate that first you must be confirmed the indication of IOL. Be sure that the indication is confirmed for IOL. It is after the age of viability. Exclude all contraindications. Assess the Bishop score first before inducing. Do the clinical pelvimetry so that the CPD can be ruled out, and assess the fetal condition also, so that the fetal lung maturity is there, the lie and presentation is confirmed. So all these precautions one has to take. And the other thing is, she has very nicely given this slide regarding the consent, because you have to counsel the patient and patient's family member that there may be risks, there may be benefits, there may be alternatives also. So they should give a consent in the era of CPA nowadays. And one thing I would like to add, before doing an ARM or induction, one should rule out active genital herpes and AIDS. In these two conditions, we don't allow the vaginal the induction of labor is to be done. And thank you very much, everyone, and wish you a lot thumping success, Sneha, and of course, Bharti in the future.
Thank you, ma'am. Thank you so much.
Thank you so much, madam.
Now we would like to go to the second part of our academic session, and I would like to invite the chairpersons for our next academic session, Dr. Anshu Jindal. Yes, can we have a CV? We are well aware of Dr. Anshu Jindal's efforts and her work on infertility, especially IVF. She is doing very well, and she has lots of publications to her credit. And we have next our chairperson, that is Dr. Naina Miglani. She is from my own society, Saharanpur Society. She has been the past president of Saharanpur OBG Society. And we have a third chairperson, that is Dr. Kavita Nagar. Again, she is the president of Mujaffar Nagar OBG Society, and she is also a very actively involved in lots of charitable services, and obviously, and she is a very good practitioner. I welcome you all, ma'am, and I would request you to please start the next, introduce our next speaker, Dr. Murlidhar Pai. Dr. Naina Miglani, will you please read the CV of Dr. Murlidhar Pai, who is going to speak on WHO labor guide. We are all waiting eagerly for this lecture. Dr. Naina. Dr. Naina, are you there?
It involves elective initiation by various means performed only for a specific medical.
Please unmute yourself, Dr. Naina. Can you please unmute Piyush, Dr. Naina?
Yes, ma'am. I think I can start off. It's okay.
Sir, I'll just welcome. Yes, sir.
Yeah.
Welcome, sir. Please welcome, sir.
Yeah, please.
Dr. Yes, sir.
Yeah.
Please.
Good evening, everyone. Thank you for inviting me for this great webinar. And let me straight away start with the talk. Yes. What I want to tell is that this new or next generation partograph of WHO is a drastic modification from what we have been plotting, that is Philippott's partograph. You will soon realize what are the modifications. This WHO Labor Care Guide was actually started in 2018, but came into practice in 2020. But unfortunately, at that time, there was COVID, and it was not really implemented by many hospitals. As I said earlier, it is nothing but a tool, A4 size paper only, to be precise, but that aims to support good quality, evidence-based, respectful care during labor and childbirth, irrespective of the setting. That means it can be used even in primary care setting, secondary care, or tertiary care level of healthcare for a positive childbirth experience. So aptly it is called next generation partograph. What are the recommendations? There are 26 new recommendations, which you will soon realize, but they have retained 30 old recommendations as well. It can be used from labor through to immediate postnatal period. If you recall, the old partogram was only for first stage of labor, whereas this can be used for second stage as well as after that. The guiding principles, a clear objective that a positive childbirth experience for the woman, the newborn, and her family should be at the forefront of labor and childbirth care at all times. So to follow these principles, what are the aims? The aims are to guide the monitoring and documentation of the well-being of women and babies and the progress of labor, to guide the health personnel, it could be doctor, it could be a healthcare worker, to offer supportive care throughout the labor to ensure a positive childbirth experience, to prevent unnecessary use of interventions, be it induction of labor, instrumentation, or cesarean section. And this would support auditing and improving the quality. It assists the health personnel to promptly identify and address emerging labor complications, somewhat the previous partogram also did. By providing reference threshold, this is very important. In the old partogram, the reference threshold was, if we remember, there was an alert line and there was an action line. But that was unrealistic. Hence, they have given different reference threshold to identify the problem and to refer to a higher center. So that's why I'm underlining they have given different reference thresholds that are identified to trigger reflection and specific action or actions if an abnormal observation is identified. For whom, as I already told, it is for women and their babies during labor and birth, regardless of their risk factor. That means it can be used at any level, number one. Number two, regardless of risk factor means low-risk patients as well as high-risk patients. However, the labor care guide was primarily designed to be used for the care of apparently healthy pregnant women and their babies, basically low-risk pregnancies. However, high-risk women may require additional and specialized monitoring and care, and you can still use the same labor care guide. Now, when to initiate the labor care guide? This is the most important slide probably in whole of my lecture, and this is the major deviation from the previous slides or previous partogram. When woman enters the active phase of first stage of labor, regardless of her parity, that means primigravida or multigravida, low risk or high risk, and the membrane status. So if you recall, the old partogram said the active phase starts at 4 centimeter dilatation. That's why I said there is a major deviation in the new labor care guide, and that is seen in this particular slide. And that is equal to or more than 5 centimeter dilatation. That's why I have written it in the biggest possible font so that this is imprinted in our minds. The old partograph started at 4 centimeters. Now, this looks little too late for people, but I want to just tell you how they arrived at this. Just before this and between the old partograph, there was one more major promotion where it was said the active phase starts at 6 centimeters. That is almost like she is halfway through or more than halfway through the labor. So WHO always tries to take a moderate view. So they said probably neither 4 centimeters nor 6 centimeters, probably 5 centimeters is the right time that we can start this plotting of the labor care guide. That does not mean we ignore the lady before 5 centimeters. We have to take care of her, but we start plotting, monitoring closely, documenting after 5 centimeters. I hope I am clear in this. Now, what is the new definition for latent phase? We all know before active phase, there is a latent phase. And we also know that this is the most variable phase. It varies from person to person. It's a period of time characterized by painful uterine contractions, all right, but they are variable changes of the cervix, including some degree of effacement. So you cannot really make a linear equation to the intensity, frequency of pain to the cervical dilatation. There is slower progress of dilatation up to 5 centimeters for first and subsequent labors. For anybody, there is a slower progression. So some women may take 8 hours, some women may take 12 hours, some women may take up to 24 hours to reach 5 centimeters. That is the meaning of this new definition of latent phase. Now, the new definition of active phase, I have already told you, that is after 5 centimeters, but how is it characterized? It is characterized by regular, that's why I've written in a big font, regular painful uterine contractions The regularity can be 2 to 3 per 10 minutes, and then it will last for 40 to 50 seconds. And of course, it is coming at a regular frequency. And the most important word here is there's a substantial degree of cervical effacement and dilatation. There is dilatation, more rapid cervical dilatation from 5 centimeters. Now, another important thing to note here in the new labor care guide of WHO is that the duration of the first stage of labor. Now, in all our textbooks, undergraduate, postgraduates, it is mentioned that the first stage is around 10 to 12 hours in primary gravida, second stage is around 2 hours, and third stage is up to 1 hour. And multigravida, it is slightly faster. But we must explain to the women that a standard duration of the latent first stage has not yet been established and can vary widely from one woman to another. However, the duration of active first stage, that is after 5 centimeters until full cervical dilatation, usually does not extend beyond 12 hours in first labors, that is primary gravidas, and 10 hours in subsequent labors. Now, I need to explain this. We need to understand this. What they are saying is, we do not count the first 5 centimeters because it is highly variable. But once she attains 5 centimeters, that is the new active phase of labor, she must deliver in 12 hours. That means they have given maximum of 12 hours for the last 5 centimeter dilatation in primary gravida and 10 centimeters in multigravida. So let us understand this clearly before we go ahead. 12 hours in primary gravida after 5 centimeters, 10 hours in multigravida. Now, the progress as told in the old partogram, that is, the cervix dilates at the rate of 1 centimeter per hour in active phase, is unrealistically fast. It does not happen. If we went by that, after 4 centimeters, she must deliver in 6 hours. You just saw in the previous slide that for 5 centimeter dilatation, we can give an up to 12 hours time for a lady, which clearly says in the old partogram, we were unnecessarily, unrealistically expecting her to deliver within 6 hours after 4 centimeters. So it is inaccurate also to identify women at risk of adverse birth outcomes, hence not recommended for this purpose, nor for identification of normal progression of labor. So labor may not actually or naturally accelerate until 5 centimeters. Therefore, interventions to accelerate labor and birth using oxytocin or cesarean section before this threshold is not recommended. First of all, we must have patience, and then we must explain to the patient to be patient, provided that fetal and maternal conditions are reassuring. So this is the biggest caution I want to tell everybody. It is not that we blindly wait for 12 hours. That's not the meaning of it. We must closely monitor the woman, and we must be very, very sensitive about the fetal and maternal condition. Should there be any problem, we should not hesitate to intervene. But only going by the cervical dilatation and intervening is not correct. That is the meaning of it. So cervix should be given ample time to dilate at its own rate, but we must be careful about maternal and fetal distress. So cervical dilatation rate slower than 1 centimeter per hour after 5 centimeter alone should not be routine indication for obstetric intervention. So that's very, very clear now. What about second stage? As I said, the new partogram or new labor care guide also covers the second stage. So they have given a liberal 3 hours. Again, I want to caution everybody, it does not mean that we blindly wait for 3 hours. What it means is we can wait up to 3 hours if everything is fine, if there is no fetal distress, there is no maternal distress, there is no caput, there is no molding, there is no unnecessary bleeding or anything like that. In subsequent labors, that is multigravidas, it is 2 hours. So it is 3 hours in primi, 2 hours in multi. Now, when not to initiate, again, this is telling in a different way. LCG should not be initiated during latent phase because it is indefinite period, isn't it? However, it should be monitored after that. Very good. Now let us go to the actual labor care guide. From a distance, it looks like an old partogram only. It is very familiar. What is missing, obviously, is that action line and alert line. Otherwise, the same it looks. Let us have a detailed explanation of each of these sections. There are 7 sections instead of 5. Old partogram had 5. The new one has 7 sections. What are they? Number 1 is, first one is identifying information and labor characteristics, which is normal, simple. The second one, I have made it bold, supportive care. This was not there in the old partogram. Third one is care of the baby. Fourth one is care of the woman. Labor progress, which was having that alert line and action line. And 6th is medication. 7th, again, I have made bold because this is a new thing, shared decision making. So these sections contain a list of labor observations. Let us go at a focused or zoomed level. So as you can see here, there is a x-axis, there is a y-axis, and there are hours. 12 hours you can see for the first stage and 3 hours for the second stage. I'm going to further zoom that in the subsequent slides. Section 1. It is basically identifying information and labor characteristics at admission. This is the simplest part of the labor care guide. Here, all that you need to enter is name of the patient, parity, labor onset, what time, and whether she is in active labor, that is after 5 centimeters. And whether the membranes are ruptured or not. If ruptured, what time it was ruptured, if there's any risk factor. This is all that you have to enter in the first section. And it is started after 5 centimeters. So for example, this is the same example which I have taken directly from the labor care guide. The name seems to be Mary Jane Williams, and she is gravida 2. Labor onset was spontaneous, and she went into active labor at around 5 o'clock. And then risk factor is history of stillbirth in the past, and there is a anemia in the present pregnancy. Now, section 2 to 7, they contain list of observations and should be recorded for all sections soon after the woman is admitted in labor ward and following subsequent assessments throughout the labor. Monitoring to action to ensure systematic and consistent application of LCG. That is, assess, record, check, and plan. This is the flow. Now let us look at this, what I was talking about, x-axis and y-axis. So as you can see, there are 12-hour slots that is depicting the active first stage and 3 hours for the second stage. And in the columns, you will see alerts. What is the alert at each section? For all observations, there is a horizontal time axis, as I told you, and vertical axis, that is the alert. I will explain further what are these alerts. Now, recording the time can be done like this. She came at 6:30, after 1 hour, 7:30, 8:30, 9:30, you can record like that. And when she entered the second stage, 12:45. So that means she took 7 hours in the active phase of first labor, right? And then she went into second stage, which is well within normal. Because again, let me remind you, WHO says you can wait up to 12 hours, right? So the second is the numbers. Now, let me go to the second section, which talks about supportive care. Now here, What are the alerts? It talks about companion. If companion was present, you will write Y. If companion was not present, you will write no, N. Companion can be anybody, including a nurse. Abroad in the West, they allow the relatives. Here also in some hospitals they allow, but some hospitals do not allow. But it's okay. Somebody should be there, either a nurse or an intern or a postgraduate or an assistant. D means woman has declined that. So what is the alert here? If you have written N in the partogram, that's not a good thing. That is the alert. Similarly, the next part is pain relief. If it is given, you will write Y, not given N, declined is D. Where is the alert here? If it is N, that is not good. Oral fluids, again same Y and D, N is an alert. Posture, they are caring about posture also. As I said, this is the new section in the WHO labor care guide. SP means supine, MO is mobile. So if she is supine, it is bad because we all know the pregnant uterus will compress the vena cava. So she should be either mobile or lying in the left lateral position. Now here is what you can see. I have zoomed further. As I said, in the column, you will see the alerts. Companion, they have already given you. Where is the alert? N means no. Pain relief, N means no. Oral fluid, N means no. Posture, SP means supine position. So these are the alerts. So how do you enter? This is another example. The same Mary Jane Williams. If we are plotting, we should plot like this. I'm only zooming section 1 and section 2. 6 o'clock she came. There was no companion, so you wrote N. So I have circled it with red. Pain relief was not given. I have circled it with red. Oral fluid was given, yes, so it is okay. Posture was mobile, it is okay. But at 7 o'clock, she was supine, so it's been circled with red. If you have understood this, now you will understand further things very easily. I can go a little faster. Now, section 3 is talking about the baby. This was very much there in the old partogram, but only the way they have written is slightly different. Fetal heart rate, if there are late decelerations, it is an alert. As far as the amniotic fluid is concerned, if there's meconium staining of liquor or blood staining of liquor, it is an alert. So how do you write it? We'll go to the next slide. Fetal position, if it is posterior or transverse, it is an alert. Similarly, caput, if there are 3+, it's an alert. And finally, molding 3+ is an alert. So let's see how to see this zoomed in. All those things are beautifully printed on the paper already, so that there is no need for you to mug it up and remember it. Okay, so all these alerts are already given there. So here you write, I'm just going step by step. So I finished with first and second section. Now I'm going to the third section. So at 6 o'clock, basal heart rate was 140, no problem. Decelerations, late decelerations, not there, no problem. Amniotic fluid, C means clear, again, no problem. Fetal position is P means posterior. I have circled it with the red color. That is a problem, but it may change later. Caput, 0. Molding, 0. I hope it's so easy and so clear. Next is about the care of the woman. Here, we talk about certain aspects of her urine. If protein is 2+ onwards, it's an alert. If acetone is again 2+ onwards, it's an alert. As far as pulse, it should be between 60 and 120. BP systolic should be between 80 and 140. Diastolic should not be more than 90. That's an alert. And temperature, it should be less than 35 and more than 35 gives you an alert. Urine and acetone we have already talked about. So these are the alerts already printed in the labor care guide. How do you enter that? Again, same Mary Jane Williams. I am going to the fourth section. 6 o'clock, her pulse is 88. Perfect. Systolic BP 120 perfect, diastolic BP 80 perfect, temperature 36.5, urine is negative. After 4 hours, because we know that BP we check after 4 hours in a normal labor, unless she is a pre-eclamptic patient where we may check every hour or every once in 2 hours. So after 4 hours also, things are in control, 96, 128, 84, 130. See, the main aim of any partogram is to make out at a glance if the labor is going on well. If you see any red circle, that means you are alerted. Very simple. And how to put red circle? Alert is there given to you as a reference point in the first column. So there is no way anybody can be misguided or anybody can't say that I forgot about it. Okay, so that's it. Now I am putting all the 4 sections, 1 to 4. This is how it will look like. Let's move on. Right, now I come to the most important part of the labor care guide. It is also most controversial part of the new labor care guide because we were all so much tuned to 1 centimeter per hour in first stage of labor in primi gravida. This is the one which shocks us a bit. So here we are talking about cervical dilatation and descent of the head. Now, cervical dilatation, which are the alert? If the contractions are less than 2 in 10 minutes or more than 5, it's an alert. Similarly, if the duration is less than 20 seconds or more than 60 seconds, it's an alert. Now, as far as the dilatation is concerned, as I said, many people jump on me the moment I say you can wait up to 6 hours. Only if it is more than 6 hours in 5 centimeters, it's an alert. Now, people will question, how can you wait for 6 hours in 5 centimeters? For this, you have to remember, I just told, between the new labor care guide and the old labor partogram, there was one more proposition where they said up to 6 centimeters, you can relax. The active phase starts only after 6 centimeters. Here, at least, we have started plotting after 5 centimeters. We can wait up to 6 centimeters. Now, the meaning of this is not that we blindly wait for 6 hours. The moment she achieves 5 centimeters, it's not that we go for dinner or we go for lunch and come back after 6 hours. That's not the case. We have to be sitting next to the patient and monitor her. Just because cervix is not dilating, we don't have to jump and do a cesarean section. That is the only meaning of this. I hope I am clear. The moment she achieves 6 centimeters, you can wait another 5 hours for her to progress further. But then, as you can see here, they have given a maximum of 12 hours in the first stage. So it is not blind waiting again. But again, these are the maximum limits, not the minimum limits. When she achieves 7 centimeters, you can wait only 3 more hours. If she remains 3 hours in 7 centimeters, you have to intervene. When she attains 8 centimeters, as you can see, the time limit comes down to 2.5 hours. And when she reaches 9 centimeters, in another 2 hours, she should achieve full dilatation. I hope I'm very clear in this. As you can see here, from 5 centimeters to 10 centimeters, maximum is 12 hours, but at each centimeters, they are given a relaxed time. That does not mean, again and again I'm repeating, does not mean that you blindly wait. Second stage, maximum 3 hours in nulliparous and 2 hours in the multiparous. So for the descent, there are no real reference points because you cannot really predict how it descends. But if there's an undue delay, you can put a X mark. And if in the second stage, insert P marks when she starts pushing. That means she is in the mode of almost bearing down. Now here, as you can see in an example, at 6 o'clock in the morning, whatever time she came to the hospital, she was already 5 centimeters. So we started plotting. Right. and she achieves 8 centimeters by 10 o'clock. How much time she has taken from 5 centimeters to 8 centimeters? Only 4 hours. So that's why I have put a green circle. On the contrary, if she took up to 12 o'clock in the afternoon, which clearly means she took 6 hours, I have made a red circle. This is the time, in the old partogram, we used to say reassess. This is the time we have to do reassessment in the new partogram. Maybe there is an undiagnosed CPD. Maybe there is uterus has relaxed. Maybe there is inertia. Maybe there is a occipitoposterior or transverse stuck. Maybe we have to consider ARM. Maybe we have to consider oxytocin. So that is the meaning of it. Let us go back to the old situation. She came up to 8 centimeters within 4 hours, and then she achieved 10 centimeters by, let's say, 7 hours. So this is a good thing, and she delivers. Similarly, the dilatation, she has dilated nicely, and the descent has occurred nicely. She has come within 6 hours to the 0 level. Now, this is the easiest part again. Whatever medication you have given, you have to enter there. If you have given oxytocin or any other drug, IV fluids, yes or no. The 6th one is the easiest one. 7th one is the new thing again. What I said, it's a shared decision making. So you have to write what actually you discussed with the patient, and you have to make a point and the decision taken. Maybe the decision was to continue with routine monitoring, or to take some more tests, or augment labor with oxytocin and ARM, or maybe you can apply vacuum, forceps, or even take her for an emergency cesarean section. Whatever it is, it has to be written there like this. So I have come to the last part of my talk. Having understood how to plot, I will just summarize what are the recommendations in 2020. In the first stage, auscultation every 50 minutes, yes, recommended. Per-vaginal examination every 4 hours, recommended. Epidural analgesia, yes. Parenteral opioids, yes, very much. You have to give some painkillers, but after 5 centimeters. Relaxation and manual techniques for pain relief, yes, go ahead. Some people, massage her back. Some people massage the tummy. That's all welcome. Maternal mobility, very much welcome. Especially if she's primigravida, she doesn't have preterm labor, she doesn't have any PROM or multiple pregnancy. Mobility is always encouraged. Of course, in heart disease patients, they have to be in the supine position, not the proper position. All those things are understood. Oral fluids, yes, you don't have to always give IV fluids. What is not recommended at admission is routine clinical pelvimetry. I have put a question mark. This is my question mark, because I believe in doing a pelvimetry, clinical pelvimetry, because it is better to diagnose if there is any CPD in the early part of labor and take her up for section straight away, instead of allowing her to go through labor pains for 6 hours and then take a decision. Second one is also, I put a question mark. They are saying there is no need to do routine CTG, but there is no harm. In fact, it is good to do a baseline CTG and take a printout also, so that should there be any problem later or litigations, we can show it. Perineal shaving is again not recommended. We can keep it clean. Enema not recommended, but if you think the rectum is loaded, I think you can go ahead with it. Routine vaginal cleansing is not recommended, but if it is very much discharge is there, you can clean it once. Intervention for cervical dilatation of less than 1 centimeter in active stage is not recommended. Further, continuous CTG not recommended, but I have put a question mark. In high-risk patients, continuous CTG is always better. IV fluids to shorten labor, definitely not recommended. Active management of labor, you can do it actually. There's nothing wrong, especially the ARM and oxytocin, but you have to choose your patients, right? And antispasmodics, that epidocin or drotaverine, these are not at all recommended. As far as second stage is concerned, auscultation every 5 minutes, welcome. Birth position of individual woman's choice, welcome. Pushing, encouraged and supported, follow their own urge. Don't say push, 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 but she knows when to push. Encourage that one, natural push. Preventing perineal tear by holding the hand or a pad is always good. What is not recommended is that routine or liberal episiotomy. This is the highest controversial topic. I can give 2 hours lecture on this. So let me just say, if you think the perineum is tight, go ahead and give episiotomy. If you are using vacuum or forceps, go ahead and give episiotomy. Application of manual fundal pressure, definitely no from my side also. Third stage, of course, uterotonics, that is active management of third stage is welcome. And then, of course, delayed clamping is the new thing. New means already 7 to 8-year-old. 1 minute at least we have to wait for better blood supply to the brain so we can prevent intracranial hemorrhage. Controlled contraction is a must. What is not recommended is routine massaging unless you anticipate PPH. So thank you very much. I hope I have clarified everything. The WHO partogram, in other words, the new one, gives you more relaxed time to accommodate all sorts of women who need not always run in the expected speed. They can take up to 12 hours, but not blindly. We have to monitor closely. We have to be alert. Alerts lines, recommendations are already given there. And finally, we have to give a good experience for her and safe delivery. Thank you so much.
Thank you so much, sir. Such a relevant and topic and enlightening on this new labor care guide. It was very informative. I would now invite Dr. Anshu Jindal, ma'am, to please give her expert comments.
I think we should congratulate Dr. Muralidhar for such a wonderful and such clarity. You made us understand this new concept. We all were more aware of the old partogram. And it's really the reference thresholds that you talked about, which this LGC really says that you should have the new reference threshold. You have clarified them so well. You've done a great job, and we have really understood today how to go about it. My only question to you is, what about IVF pregnancy? I'm an IVF expert. So what about IVF pregnancies? What are the special things for them for high-risk pregnancies? This is for the setting you set.
First of all, let me ask this in a lighter vein. Is anybody thinking of vaginal delivery in
No, not really. But the WHO should have a recommendation for that.
No. See, talking theory is one thing, and practicing is entirely different.
Let's talk about high risk, not IVF, but non-IVF.
Yeah. We have to bring the gap between the theory and practice. That should be the aim of all of us. While we can't be totally theoretical and burn our fingers, at the same time, just we say I'm practical and do 100% cesarean section. Now, even though labor care guide, the new one, claims that it can be applied in low risk as well as high risk, there is a disclaimer or there is a rider right in the beginning. I told, as far as high risk patients are concerned, you can use it, but the thresholds can be slightly lower. Maybe you don't wait for 6 hours in 5 centimeters, or maybe you don't wait till late deceleration appears, or maybe you don't wait till the full-fledged caput molding everything happened, or maybe you don't wait till the everything has gone wrong and take. So everywhere you have to be a little bit more careful. As that's why I said some of the recommendations I am not agreeing. Especially the non-recommendation.
Specified them in the end, which was very true.
Yeah. So I said continuous monitoring is always welcome. And in fact, in Manipal, we used to tell our PGs every hour you take a 10-minute trace, take a printout, keep it in the thing, because we don't know when which patient is going to put litigation on us. And this is the only graph that will save us, saying that it was all right, then we didn't miss it and things like that. And also, we can't, in any field in science as such, we can't be dogmatic. And you cannot, the worst thing is quoting that labor care guide says like this, or another recommendation says like that, and things like that. And because it is nice to make an argument in the court maybe, but if the lady loses, we have lost.
Yeah.
We have lost the game. We may win it in the court, but we have lost the game and we can't excuse ourselves.
Yeah.
The court may excuse us.
And the shared decision making, I think, and supportive care, I think the two columns that they have added they're going with the trend because shared decision making is the norm. I think it's
Yes,
very
yes.
important.
No, this is in fact those who know, if there are any postgraduates or younger generation who is planning to do MRCOG and all that, the
Yeah.
MRCOG exams will only talk about shared decision making.
Yeah.
They take it for granted that you know obstetrics already. That's
Right.
a good thing. You know obstetrics, you know gynecology, but tell me, how do you teach obstetrics to the patient? How do you teach gynecology to the patient and convince the patient for your decision, which is her decision also? That is the main focus currently, and that's why they have added that. And also in the supportive care, I know that practice has been there in the West for a long, long time. In Manipal also, we with enthusiasm started allowing husbands and all that. But then we realized we have to train the husbands properly during antenatal care, because some of them can't really sit next to the patient who is laboring, and they will be more tensed up, and we will be taking
Flabbergasted,
care
I
of
think.
them
Mm.
rather than taking care of the lady.
Mm.
So we have to adapt it to our situation. We can't be blindly following everything. For understanding, I given a full lecture, but with lots of caveats, with lots of disclaimers, and with lot of cautions.
Thank you. Thank you so much. Thank you for the lovely talk.
Yeah, thank you so
Thank
much.
you, sir. I would like to have your comment on the recommendation that is coming in India also regarding the strict use, including of autograph in the entire case sheets and all. Can you
No,
just
no,
comment
it
on
is
that
a no,
section?
no, it is a must. In
Yes.
Manipal, we were very religiously and strictly using the old partogram. But in 2020, when this came, I just left Manipal and I've come to Sikkim. I'm sure they are using it there. Here, I'm as much as possible insisting that we must, because this is not only a guide, this is a document. This will save us. This will save us also, and it will save many babies, mothers, and it is always good to this, and it doesn't take much time. Usually what PGs do is they at the end of delivery they start filling this. That is a wrong concept. This has to be live, and it is like a live commentary. We have to, and it is so easy. It is all printed there. We have to just write, make some entries. Okay, so I think we must insist.
And a
So
red pen. And a red pen to mark it.
red and green, so that it becomes a practice for them, and they can answer in the exam also. When you routinely do it, it becomes like a habit, and then it's there in you. Zehen, it is in your zehen.
Thank you, sir. Thank you so much. This was a very, very much needed eye opener for not only the new practitioners but also for everyone practicing obstetrics. Thank you,
Thank
sir.
you.
Thank you so
Thank you,
much, sir.
Dr. Pai.
Huh?
Dr. Pai, thank you and
Yeah,
welcome in the UPCOG. We are really very grateful that
yeah.
you have given a wonderful lecture in the UPCOG. Bharti Maheshwari here, sir. Hello, can you hear?
Yes, ma'am. Ma'am, your video is not there. I was just wondering from where.
Yes, but you can hear my voice.
Yes, yes, no worries.
Dr. Pai, you can hear me?
Of course, I know. I
Yes,
can
sir.
hear you.
Sir,
I
so I
can
am
make out
very
your voice,
glad
even
that
though I can recognize you from your voice.
yes, so I am very glad that you have
Yes.
come in UPCOG and given such a wonderful talk. And I think we will continue to have you in our coming webinars also. And
Yes.
thank you,
Okay.
Sneha, that you have invited Dr. Pai.
Yes,
And
sure,
really,
sure.
sir, wonderful, very informative. Yeah.
Thank you so much, sir. So we are always very happy to have Murli sir here, because I think this is almost third talk, sir, on the same topic, because, I really want to, I would just say that I'm practicing obstetrics since last 32 years, and I'm practicing obstetrics even today, the same zeal and enthusiasm. But what I would say that, initially that masterly inactivity, watchful expectancy, now that, O'Driscoll's follower, the active management of labor, and again back to this WHO labor care guide, again going towards, do nothing, just watchful. And what
Yes.
I suggest is, it has to be a vigilant monitoring and timely and appropriate intervention that should save you and your patient as well. So, sir, always have guided us very well, and I'm sure we are going to have many more sessions, not only on this topic, but other topics also.
Yeah.
So, thank you, sir.
Always have pleasure to be part of your webinars, Dr. Sneha.
Yeah.
Thank you, sir. Yes, sir.
Thank you, Muralidhar sir.
Yeah.
And I would also like to thank our chairpersons, Dr. Anshu Jindal, Dr. Naina Miglani, and Dr. Kavita Nagar. Now, I would like to come to the next part of yes, sure, ma'am.
Yes,
Kirti ma'am,
Madam
yes,
Kirti Dubey,
yes, please,
please.
ma'am, please.
I also welcome Dr. Vidya Thobi and Dr. Rajeshri Paladi from
Yeah, thank you very much.
Such a wonderful talk, and the only thing what we all have to learn, even being senior obstetricians, that it is patience. This new WHO 2020 has taught us that we have to learn more patience rather than what we had. From 3 to 4 we came, and from 4 to 5, and from 5 to another 12 hours. Thank you so much for bringing this into focus, and we'll try to follow. Thank you, Dr. Murli.
Thank you.
Thank you.
Thank you, ma'am. Thank you, Dr. Vidya Thobi.
Thank you very much.
I
It
can
was a
also
really
see
wonderful talk. Yeah. I
Rajeshri Paldi
joined from
also.
Karnataka. Yes, thank you very much. And it was a
Thank you.
wonderful talk. I have one comment. Sometimes we have to read between the lines,
Yes.
and we have to take the decision accordingly. We
Yes.
cannot 100% believe in the documents.
Yes.
And I know that the patience really teaches us, but the monitoring definitely helps us. Thank you. Thank you very
Thank you,
much.
ma'am. Thank you.
Thank you.
Thank you, Pai
you.
sir, and thank you, Sneha ma'am, for having us on board. It is always a pleasure to listen to Muralidhar sir's talk and his experience and expertise in the obstetric management. Thank you.
Thank you so much, all of you. It's my pleasure to have all of you here.
It's great.
Please go ahead.
Yes.
Thank you. Thanks, dear Anshu.
Hello. Yes. Now we have come to the most interactive and dynamic part of our academic session, and that is the panel discussion on labor emergencies. And I would invite our active and keen academician, Dr. Sneha Bhuar, to take up this session as the moderator of the panel discussion on labor emergencies. Can I have a CV, please? For that, I would like to invite our chairpersons, Dr. Anuradha Khanna ma'am.
The experts for the panel. The experts for the panel.
Experts for the panel, Dr. Anuradha Khanna ma'am and Dr. S.P. Jaiswal ma'am. Warm welcome to Anuradha Khanna ma'am, the senior academician from
Have they
BHU.
joined, Dr. Nutan? Have they joined?
Yes. Anuradha Khanna ma'am was there up till now. Let me just check.
Go ahead with the introduction.
Yeah. Anyway, we'll I'll just connect with her by the time. Let me also introduce SP Jaiswal ma'am. I think she had joined, but I can't see her name here. But SP Jaiswal ma'am is also our expert in this panel discussion, and I'll connect and will introduce, welcome her if she connects again. By the time I will welcome Dr. Sneha Bhuar ma'am to take up the panel discussion. Dr. Sneha Bhuar ma'am, and because
Please
of the
introduce all the panelists just in short in
yes,
one
ma'am.
or two points. And,
Yes,
yeah.
yes. We have quite a gathering of panelists here. We have Dr. Vinita Malhotra from Saharanpur, and she is a very, very active in vaginal surgeon. We have Lalita Manwal, a young dynamic obstetrician from Saharanpur. Then we have next slide list. We have Dr. Priyanka Garg. I welcome her. She is the treasurer of UPCOG, a very, very dynamic person from Meerut. We have interacted with her number of times. She has successfully co-hosted number of seminars like CEFCON, SOPAB, and many more. Welcome, Dr. Priyanka. We have Dr. Rachna Chaudhary from Meerut. She is the professor and head of department from LNO Medical College. Rachna ma'am, we welcome you. And we have Dr. Manju Gupta ma'am. She is a senior obstetrician and gynecologist from again from Meerut. Welcome you ma'am. And the next slide is of Dr. Maya Chaudhary, who has done her fellowship in IVF and laparoscopy. Dr. Maya is a very, very young and a dynamic IVF keen IVF specialist. Next slide, please. Again, Dr. Anisha Rai, I welcome you from Mao. She is a consultant in Asta Nursing Home. Welcome, Dr. Anisha. Again, we have Dr. Pramodita Singh from the Mao Society. She has again a clean obstetrician and gynecologist, very young and dynamic practicing obstetrician from Mao. I welcome all of my panelists, and I would request Dr. Sneha Bhuiar ma'am to take this academic session further with a panel discussion.
So actually, I will start with the panel discussion without much ado, but I would request Dr. Nutan to share the fresh faculty link with Dr. S.P. Jeswar. She's not able to join. Please share. I just talked to
Yes,
her.
yes.
So, yeah. So can you please
That's-
stop sharing? Please stop sharing, Piyush. Please stop sharing.
Ma'am, I've stopped.
No, you can see, I'm viewing the Corona Remedies screen share again. I can see the same thing. It's not stopped. Now I'm doing that. Let me see. What is wrong? I can see your screen still. Hello?
I've
Hello?
stopped, ma'am. I've stopped, but I'm making you the co-host so that you can reshare.
Yeah, but then I can see you, Corona Remedies sharing the screen. Yeah, now I can see that you have stopped sharing. So sorry for that technical glitch, and I hope you all can see my screen, and I make it full screen. Is it? Can you see the screen?
Yes, ma'am.
Okay.
It's visible, ma'am. Please go ahead.
Okay, thank you so much. So friends, I have already
Ma'am, I have resent the link to you, ma'am. Please join.
Yeah, you mute yourself, Dr. Nutan. Please mute yourself. So friends, we are here to start with the panel discussion. All of you have heard what the views about labor. Everybody is expressing the intensity of how all the obstetrician, should take up the labor on priority. So friends, childbirth is a sentinel event in the life of a woman and her family as well. It is intensely emotional as well as intensely physical event. It's not, 1, 2, 3 pushes and the baby is out and everything happy, not like the Hindi movies. But, you are just waiting and waiting for the patient to deliver, and no matter of time she can be in the ICU. So you really have to be, very careful. The very essence of normal labor is delivering a healthy baby from a healthy mother, and of course it should be an emotionally fulfilling experience for the mother and the family. I would say very confidently that in spite of having long years of the experience, including me, 32 years of my experience in the field of obstetrics, the dilemma still exists. So the management of second stage of labor remains for many obstetricians, both during their training as well as with the long experience. It remains an area of confused thought. Masterly inactivity and watchful expectancy. So with this brief introduction, I would go ahead with the panel discussion, and we would start with the first panelist. So this is a grand multigravida 35-year-old delivered by a Dai at home. The placenta is also removed at home. So she's brought to the labor ward with profuse bleeding. Her vitals are, pulse rate is 120, her BP is 90/50. So I would ask the panelists, what is your diagnosis from this history and the findings? Who will take up this case?
I can, ma'am.
Yeah, please go ahead. With this history and only this much of findings, what is your diagnosis?
Case of PPH.
It is a case of postpartum hemorrhage. Now that we go ahead and, you know, they give us further examination findings here that per abdominal, the uterus is not palpable, bleeding is profuse, and, you know, there is a fleshy mass seen at the vagina. You can't see you can't feel the cervical rim. Now, what is your diagnosis, Dr. Vinita?
On examination, it is a clear-cut diagnosis of acute inversion of uterus.
Correct. So this is the picture, acute inversion of uterus. So how would you classify it? And for this event, how will you manage as an emergency?
As an emergency, I will like to deposit on that time only. With the help of little tocolysis and analgesia, I will try to reduce this there and only. The part which inverted
for our patient, the patient is delivered at home. Okay, she's delivered at home. The placenta is removed, and she's brought to the labor ward with profuse bleeding. So there is definitely some time, you know, has lapsed. So will you be able to repose it?
I will try, ma'am. I will try definitely. I will firstly resuscitate the patient and
Yes.
then try there that time only to reduce the inversion. The part inverted last, I will deposit it. I will try. Definitely, I will try with the help of little tocolysis.
Yes, but without anesthetic, because the patient is already in shock. If you try and reposit and she goes into vasovagal again, then she will go into hypertension, right?
If the anesthetics will take
Yes.
time to come, so I will give some analgesia or nalorphine or morphine and try to resuscitate. Try to
you try to resuscitate and try to, you know, repose the uterus. So this is how you have done. How will you go ahead?
I will take my hand
yes
in a shape, and I will try to I will keep my finger at the this palm on the top of the mass and on finger at the last part, and I will deposit the last part first, and later on the part which inverted last will go last. And I will keep
the part which has come up last will go first. Okay. The cervical, the part near the cervix, you know, the cervical rim which is inverted will go first. You start like this, the inner portion first, and then the fundus will go last. Then you will keep your fist inside and
I uterotonics till uterus contract.
Before that, with your left hand, you stabilize the uterus.
Yeah, I will keep my left hand on the abdomen, uterine abdomen, and fist inside the uterus. Perfect. And then I will give uterotonics, and I will keep my fist there till uterus well contract.
Well, yes. And uterotonics for how long?
Till uterus contracts, well contract.
Yeah, but then definitely for first 24 hours. Okay, because these are the uteri which are, you know, flaccid, hypotonic uteri. So they tend to recur. The inversion tends to recur for first 24 hours. So even if you have the good uterine tone, you have to keep the uterus in well contracted condition to prevent the recurrence. Now, suppose this doesn't help, then what are the other methods you will try?
I can try hydrostatic correction also.
How will you do that?
In that we can push through. I can
anybody else can take up. Anybody else? Somebody can volunteer, please.
So hydrostatic method is a very good method, especially for patients who are being referred from home, who didn't deliver with you. That is the simplest part. So patients who have been referred, what we use is we use that simple soap. Water enema can. We put it on a outlet first so that the water doesn't come out. And with increasing pressure, it will beautifully go on its own. The moment it is reposited, again, remember that put in your hand, keep massaging the uterus, start uterotonic, and when the tone comes out, then only remove your hand.
Perfect. And again, the same thing that you have to maintain the uterotonics for first 24 hours, cover the lady with a good antibiotic. So whenever the manual reduction or hydrostatic, approach fails, then of course the surgical approach is imperative. So Dr. Lalita, how will you go ahead with the surgical management? Because this is much time has lapsed, so maybe you have to go for it.
Yes, ma'am. Thank you so much.
I would request you to please log out from one device because it's making echo. Okay, two devices simultaneously. Please unmute yourself. Please unmute yourself. Unmute. Unmute, please, from the iPhone.
Please, Lalita, unmute yourself.
Yes, ma'am.
Yes.
Yeah, so Nutan, you please mute.
Yes.
Piyush, please mute others. Yeah, so you can speak. What surgical approach you have to go?
Ma'am, in surgical approach, we can go for some maneuvers involving first we go for laparotomy. The procedure name is Huntington's technique. In this, we give the traction on the dimpling part of the fundus with the help of two Alice forceps and keep stretching from down to above and unfold the dimpling part.
Okay.
And we can also go for another maneuver, that is the Holton's technique. In this, we make a vertical incision over the posterior aspect of the uterus, and with the help of Alice forceps, we can hold and start defolding the dimpling part. And after that, we'll repair this. We make the incision, then we start.
Okay, so you have first the simple technique, though surgically you open the abdomen, you pack the bowel, and you put your one hand in front and one hand behind the part of the uterus, and you try to flip your fingers like this,
up,
up like this, so that the dimple which is gone down, slowly it can come up. That is one way. And then of course what you are talking about, that the Huntington procedure, where you have to actually like this, with the help of Alice, you catch hold of the round ligament first and try to just give a gentle traction on this, and slowly you try to march ahead centimeter by centimeter till you reach the dimple of the fundus. And what you said about the of course the incision, definitely you have two types here, the posterior as well as the anterior. So here you have to first take an incision. You first, before taking the incision, you may just try and dilate manually the cervical rim.
Yes.
That also doesn't help. Then of course you have to go for what is this Walton's procedure, where you have to give the incision in the posterior aspect, and you try to reduce the, like this, the fundus, because of the incision, the cervical rim is now relaxed. You pull the uterine fundus up like this, and then you close the incision, whatever you have created. Then of course you have the various pressure methods like this, like a like baby said, you do it with the vacuum cuff, and then of course the balloon inflation, you can also do this. So then there are the spinals, the Kushner's method and all these things. But if everything fails and the patient has come to you very late, there's almost the fear of gangrene, then of course you have to go for hysterectomy. Hysterectomy has to be the last resort and not a routine management. What I was talking to you about this, oxytocin you have to keep for at least 12 to 24 hours, if not at least 12 hours. Okay, because these are the vitri which again tend to prolapse or get inverted again and again. That is why the uterotonics have to be maintained for at least 12 hours, and of course the broad spectrum antibiotics. So though this inversion of uterus is quite uncommon, I won't say rare, even at cesarean section, I'm sure many of you must have perceived that when you are sometimes trying to remove the placenta, the fundus can try to come in. So you have to be really cautious about it. And if at all you find that the uterus has a tendency to get inverted, try to repose then and before the patient goes into vasovagal shock. So that will, avoid all these complications. So very well discussed, Dr. Vinita, and of course, Dr. Rachna. So with this, we go ahead with the second case. And may we have Dr. Priyanka here? Dr. Priyanka? Dr. Priyanka Garg? Nutan, you try to call her if she can join, please.
Okay, ma'am. Okay.
Yeah, and by the time, yeah. So we have, yes.
She could not join. She is in some emergency.
Okay, we go ahead. So anybody can take up this case. We have this primary gravida, 37 weeks pregnancy. She came in labor, and here we have the vitals, the normal contractions, the mild contractions, 25 seconds every 4 to 5 minutes. Head is floating. The fetal heart is very good. You find that, she is in early labor, and there is sudden drop in fetal heart. So what is your diagnosis, and how will you manage?
Can I take the case?
Yeah, please.
I think this is a case of cord compression or cord prolapse, ma'am.
You tell me what is your diagnosis?
Because ma'am, head is floating and contractions are suboptimal. They are not optimal contractions, and there is, I think, just of cord compression is the most probable.
But then for cord compression, you have to have some reason. No, here head is floating. So how will it get compressed? How will it get compressed? You have to have some reason for compression. Either there is liquor is less, or maybe there are very strong contractions. It is getting caught up between the present.
It looks more like prolapse.
Perfect.
Because in cord compression, you have more of variable deceleration.
Yes.
And because this patient has bradycardia, so goes more in favor of cord prolapse.
Yes. So how will you come to the diagnosis? What will you look for?
Ma'am, cord will prolapse if membranes are absent.
Yeah, so that is the reason.
So membranes are absent.
You have to look for that. Even if the patient is in early labor, because the head is floating, you have to keep a watch that she should not have spontaneous rupture of membranes. Okay, and if at all she has spontaneous rupture of membranes, you have to make sure that the cord is not coming down. Okay, that is how you have to. But this lady, when you are suspecting this, immediately you have to do a post speculum examination. See that if there is leaking, see what is the color of the fluid also, and see whether the cord is palpable or no. Okay, so that is about cord prolapse. Now, how will you come to the diagnosis what Dr. Vinita was talking about? I think the next person can take up this. We have lots of panelists here, Dr. Maya Chaudhary, Dr. Nanita, Chandra. All of you can participate, please. Yes, Dr. Maya?
Yes, ma'am.
Yeah. So how will you diagnose? I've given you a clue that the moment she, her fetal heart goes down, you do her internal examination. Should you do her internal examination?
As you said, ma'am, we should always do a post speculum examination then to rule out cord prolapse.
Yes.
So that is how we'll diagnose that there is cord prolapse.
Right.
So never be in a hurry in such cases. Don't try to deposit it back inside and elevate the fetal.
So how will you manage? Now that your diagnosis is very clear, we will go to the theoretical discussion later. How will you manage this case that there is a certain cord prolapse in fetal distress?
So we can give head low position to the patient so that the compression on the cord is relieved somewhat. And
what
then
is your management plan? What is your management plan? You tell me first.
We will take her up for cesarean section.
Okay. Then by the time, meanwhile, what will you do?
Meanwhile, we can give her left lateral position, head low position, and give her IV fluids, and continuously keep a check on her fetal heart. It is very important to check the fetal heart even before you give an incision for the cesarean section.
Yeah. And of course, you try to give her oxygenation. Maybe try to give her. You at the earliest you have to take this patient for cesarean section because she's just in early labor anyway. She is not going to deliver, right? So for fetal distress, you have to take her up for cesarean section at the earliest. Even if this patient was in advanced labor, you have to deliver this patient by whatever way at the earliest. Okay. So mode of delivery may be different, but for this patient who is in early labor, the message is very, very clear because it's a cord prolapse and the fetal distress is there. So you have to deliver this patient at the earliest, right? Okay.
Dr. Sneha,
Yes.
I'm Dr. S.P. Jaswar.
Yes, please.
Yes, ma'am. Welcome, ma'am.
I joined just now.
Welcome.
Welcome,
in
ma'am.
the-
Yeah.
Thank you so much. So
Yes,
whenever this situation occurs, immediately what you have to raise the buttock of the patient and down the head, and at the same time try to fill the bladder. So once the bladder fills, the head will go up and the cord compression will reduce. And the same time prepare the OT and anesthetist for the cesarean section.
Yes.
And oxygen, this is okay, but we have to reduce the compression as early as possible to reduce the fetal hypoxia.
Yes, that is what. Meanwhile, the arrangements are being done. You can see here head low position, left lateral position, even the knee chest position, which is supposed to be very good for this baby. And then, of course, manual elevation, as madam has said, making the bladder full or elevating the presenting part. Use of tocolytics. If the contractions are very severe, not for this case, definitely you have to deliver the patient at the earliest. That is what the message. And thank you, madam, for adding values to this discussion. So the question is very clear, Dr. Rachna, for you. See, this patient had floating in labor. Can we avoid such situations? And what are the, what message you want to give that what are the predisposing factors and what are the aggravating factors, when we should diagnose, what we should do?
Okay, so taking the first question, that can we avoid this situation? Definitely.
Yes.
So whenever you have a free floating head, especially in situations like malpresentations or polyhydramnios or second twin, especially in multiple pregnancy, so don't do an ARM.
Correct.
So let the head fix first before attempting an artificial rupture of membranes. If suppose due to any reason you have to do an ARM and the head is not fixed, then ask an assistant to push the head down and do a controlled ARM. Make a small hole, keep your fingers there and let the fluid escape slowly so that the cord doesn't come. Once the liquor has drained, again ascertain.
Yeah.
Yeah. If it is a tense bag, even if you use a needle, it will rupture with the whole liquor will come out. Unless until the bag is soggy, then only you can do it with the needle.
Yeah.
Otherwise, it doesn't make a difference. As for predisposing factors, one of the most commonest cause for cord prolapse is malpresentation, and that too a transverse lie.
Yeah.
And following transverse, we all advocate the second is a footlink breach, for which ideally the moment you diagnose, you should take up for cesarean. Apart from that, prematurity, polyhydramnios, second twin in multiple fetal pregnancy, and also polyhydramnios due to any other cause, they can all cause cord prolapse.
Definitely the transverse lie and breach presentation or even the abnormal lie and malpresentations, they are very, very, prone for cord presentation also, cord prolapse also. So we will differentiate it later. So as we have, already said that for such patients, definitely a no-no for augmentation of labor when the head is floating. Definitely try to avoid the artificial rupture of membranes, as Dr. Rachna has given the very good message. It has to be a controlled ARM, and of course, not to try even the manual rotation of fetal head because, the ball valve mechanism doesn't work here.
Yeah.
Now, what are the Green-Top guidelines? If at all you diagnose such patients antenatally, can you have, can you prevent such conditions? So what are your recommendations for this? That is what the next question for you only, Dr. Rachna.
So recommendation for preventing it, again we have discussed, don't do ARM in free floating heads. For patients who have a moderate to severe CPD.
Antenatally before we can do something, right? We have discussed the intrapartum, that not to do ARM if at all, yeah. So antenatally, if you diagnose, you have persistent transverse lie, persistent breech presentation 36 weeks and beyond, then of course you have to label these patients at a high risk, and you have to, advise them to avoid all this strenuous activity. You have to advise them that to be in touch with the obstetrician gynecologist as soon as possible they go into labor. That means even during early labor. And then of course, for the breech, you have various recommendations whether you should go for ECV or no. That is again a controversy. But transverse line and breech presentation near term, definitely these patients should be warned, and they should be informed the possibility of the cesarean section, and they should be given the informed choice regarding ECV or planned cesarean section, or informed decision for going for the vaginal delivery. So all these things have to be kept in mind. And of course,
one thing I want to add is that whenever you have these patients who are at high risk for cord prolapse, put them on electronic fetal monitoring. That is the earliest way to diagnose, especially variable decelerations and prolonged bradycardia. It is almost a short sign of any cord accident.
Perfect. So in continuation with this, whenever you have, this, what is we have discussed is about the cord prolapse, but we can have the cord presentation per se, right? So what is cord presentation? I would ask Dr. Maya Chaudhary first, then we'll continue with the discussion.
Cord presentation is when the cord is lying just adjacent to the presenting part.
And in between, no? Cord presentation, the cord is the presenting part.
Yes.
But it lies in between the presenting part and the membranes. That is why
membranes have not ruptured. Bag is not ruptured.
Yeah, so bag is not ruptured. Suppose you diagnose this antenatally. So what is our recommendation here? What, in continuation with what Dr. Rachana was talking about, what is the recommendation? The near-term ultrasonography, and some people have, like you have admission test for NST, you have the labor room admission ultrasonography for at least for such high-risk women, right? So once you diagnose cord presentation, absolutely no attempt to go for vaginal delivery, right? That is what the recommendation is. The moment you try to induce, augment, or go for rupture of membrane, these membranes are going to rupture, and she may land up into cord prolapse. So you have to prevent such situations by early diagnosis, labeling them as high risk, and then of course you have to take them for elective cesarean section, right? So we come to the third case. Now I'm taking these short cases because all of you know the details, the theoretical aspect. We are covering only the practical aspect. So we have this fourth gravida with 3 spontaneous abortions. Now 39 weeks in labor. She delivers a full-term baby girl, placenta not expelled, almost for 45 minutes after birth. And, so what is your diagnosis, Dr. Maya?
So it is I'm expecting that we have already done the active management of 3rd stage of labor, and still the placenta is not delivered even after 30 minutes of the delivery of the baby. So in such case, then we'll go for manual removal of the placenta under general anesthesia.
Okay. For this patient, whether you would like to rule out something before going for manual removal? Because at no point of time, nowhere I have mentioned that she is bleeding, right?
Yes, ma'am.
Okay. So will you straightway go for manual removal of placenta, or will you do ultrasonography for this?
I think Maya is not able to call because there's a history of 3 abortions, previous 3 abortions.
I would like
and
to
ask the
take
history.
Yes,
History of any curating. So there is chances of morbid adhesion of the placenta. So before going MRP, manual removal of placenta, we have to confirm whether the placenta is adherent there or not. If it is adherent, you will not able to do the manual removal of the placenta. Then you have to counsel the patient and take a proper decision what you are going to do and counsel the patient.
Okay, so the message is very, very clear that when you have a high-risk patient, especially even if there is no previous cesarean section, mind well, it's a uterine surgery of any kind, may it be cesarean section, myomectomy, or simple curettage. She has had 3 curettage maybe in the past. So she is a high-risk patient for, placenta accreta or morbidly adherent placenta. Not only this, the patient has, in spite of, as you rightly said, even with active management of third stage of labor, she has not separated her placenta for 45 minutes, but she is not bleeding. Okay. So if she is not bleeding, that is a worse sign. Okay. So it's our duty to rule out the morbidly adherent placenta, and then you should go for, once you rule out the placenta accreta spectrum, then definitely you can go for the manual removal of placenta. And then how do you do that?
Yeah, for manual removal of the placenta, it is done under general anesthesia. So after emptying the bladder of the patient, the patient is under general anesthesia. So taking cord as
These are few more things that whenever you have these patients of recent placenta, first and foremost, you will see that her bladder is not full. Uterus is not flaccid. So you will start few uterotonics also simultaneously. Right? Okay.
So yes, ma'am, we'll start the urotonics. So taking left hand is kept above the uterus abdominally to put the counter pressure. Taking the right hand cord as the guidance, we'll put our hand inside the uterus, then try to find the margin of the placenta. Once you find the margin of the placenta, we put our hand between the margin and the uterus in such a way that the fingers are opposing to the uterus and facing towards the placenta. Then by slicing movement, we'll try to take out the placenta. Simultaneously, keep the pressure by your left hand on the uterus from the abdomen side to put a counter pressure, and then deliver out the placenta.
Okay. So this is what actually I would say that, for these cases, what you are talking, left hand on the uterus and for contraction, that you have to do it during third stage of labor, the active management. But here, when you are pulling or maybe giving little traction on the cord by your left hand, but ask your assistant to hold the uterus back so that to avoid uterine inversion, right? Okay, so you have, you wear the high level disinfectant gloves, and then slowly you follow the cord, reach up to the lateral margin of the placenta, insinuate your hand like this and slicing. And then once you separate everything, like as if you're turning the pages of the book, you remove, and then whole thing you remove. Then what will you do?
And we'll check for the placenta, whether it has come completely outside or not. Keep the urotonics on for the patient.
Yeah, before that, you have to add some uterotonics, to keep the uterus hard. And then you examine the placenta, maternal as well as fetal aspects, right? To see that everything has come out. Okay.
Whether it will deliver completely or not.
Okay. So I think sometimes you do face these situations, but once you diagnose, because unnecessarily the patient who has come to you, unnecessarily the stable patient, you may make her unstable if you just try and pull the cord and you try to separate the placenta. So not in a hurry. If the patient is not bleeding, even if she's bleeding a little, you have to make sure that this is not a case of placenta accreta spectrum, because nowadays these are rising. The frequency is very high. So we have to be cautious about placenta accreta spectrum. At least you rule out placenta accreta spectrum, right? So thank you. Yeah, yes.
Ma'am, there is a question. If still after doing it in a general anesthesia, we are not able to remove the placenta completely, then what will be the treatment after that?
In fact, that is what we have said, that we have to rule out the morbidly adherent placenta. If the placenta is not morbidly adherent, then of course, with all your efforts, emptying the bladder, giving good uterotonics, and what you are doing, manual removal of placenta, it has to be, because it's a plane of cleavage, so it has to separate.
If you have, excuse me, once the placenta is not coming, patient is not bleeding, and with slight pull, if you feel it is not coming after giving the uterotonics, do the ultrasound, because we always have ultrasound and Doppler in our labor room.
That is what the message is.
Whether it's adherent or not adherent. If it is adherent, morbid adhesion of the placenta, don't try to remove it from down. In that condition, you have to take consent properly. We are trying to remove. If it is not, you may land up into the hysterectomy. So in that, the blood should be there, consent should be there. Then you do. Otherwise, in between, if you are stuck in between, then you will not be able to come out. So
Yes.
we have to, because at present the patient is not bleeding, we have enough time, we have to rule out and then go for the further. Clear? Because
ma'am.
sometime if the placenta is not coming from manual removal, then we have to open the abdomen. Clear?
Message
Yes, ma'am.
remains very clear that not retrospectively, but in fact, I would suggest that the moment the patient comes to you, she is not bleeding, she is stable, take your time and do ultrasonography rather than trying to pull and then it is not coming and then you do the ultrasonography. It is always a good practice to put in a probe and see that there is, no morbidly adherent placenta. Okay, so it's a well discussed case, and now we go to Dr. Anisha Rai. Do we have Dr. Anisha here? Yeah. So
Good evening.
Anisha, yeah, good evening. So Anisha, here we have a second gravida patient, 36 weeks pregnancy. She comes to you with history of previous one vaginal delivery, and she comes to you with strong labor pains. Okay, her vitals are good. Fetal heart is good, 140 per minute. Cervix is fully dilated, fully fixed, and you find that the breech is there. Station +1. Pelvis appears adequate. She has had one previous vaginal delivery. How will you manage this, my dear?
Ma'am, in this case, the patient, we will inform the patient party about the morbidity that is associated with breech delivery, normal delivery of a breech baby.
We won't call it normal delivery, my dear. If it
Yeah,
is
it is an
a
assisted breech.
presentation, then only we will call it normal.
If we are going for assisted breech delivery, it should be informed to the patient
vaginal
that
delivery.
what. Yes, ma'am. That what perinatal morbidity is associated with it. As the patient is having strong and with the availability of bedside ultrasound, we would like to do an quick ultrasound to see if there is hyperextended head or not, or if there is any anomaly associated with the baby. The baby is not hydrocephalus, no anencephaly is there. Then and everything is normal, I'll go for assisted breech delivery.
Okay, by the time you do everything, the baby is in your hand. She
Yeah,
by spontaneous.
Yes, so maybe it is a spontaneous.
You baby is so lucky that majority of the times because she's fully dilated,
Yeah, she's fully dilated. Yes.
+1, and she's pushing. So by the time you do everything, she can have spontaneous vaginal breech delivery. But yes, you're right. You may have to go for assisted breech delivery, right?
Yes.
Okay.
Yes.
So here, how do you conduct the assisted breech vaginal delivery?
Ma'am, first is partial breech extraction and the other one is complete breech extraction. In partial breech extraction,
Can we do this for vaginal delivery, complete breech extraction? Or should we allow the patient to deliver?
We should allow the patient to deliver spontaneously. If she's having good uterine contractions, she's having good labor pain. We should allow to deliver the breech should be delivered spontaneously. If not, then we should try for assisted breech delivery.
Okay. So the breech has delivered. What next? We are conducting the assisted breech vaginal delivery.
Yes, ma'am. When the breech has delivered, then for the delivery of the legs, we will insert our 2 fingers and we will insert our 2 fingers and we'll sweep the legs with a lateral flexion and abduct it, and with the delivery of the legs, we'll then after the delivery.
Okay. So I'm sorry, because the baby got stuck because it's a frank breech. How will you
do it? If it is a frank breech, then frank breech is okay. Frank breech has delivered.
Yeah, but then it's
the legs is delivered now. Yes, ma'am, the legs is delivered, and following
the legs are stuck up like this.
Yeah,
I'm saying that it is stuck up like this. Then how do you deliver it?
Ma'am, then we splint.
It's not a complete breech. It's not a complete breech. I'm saying that if it is a frank breech, how will you deliver? The baby's breech is hanging, the buttocks are hanging, the legs are going up like this. Then how will you deliver?
Breech. Anisha, it is an extended breech where the footlings are beside the head.
Yeah.
Yes. Yes, ma'am. The legs are sequentially delivered by splinting action of the middle finger.
Yeah, so
As-
you give with your one hand, you give a tap in the popliteal fossa.
Popliteal fossa.
The
This is called
ankle will
Pinard's,
come.
yes,
Yeah.
ma'am. Pinard's maneuver.
That is
Yeah.
Pinard's maneuver. Yes.
Pinard's maneuver, and then then when the foot is within our reach, we grasp it
Okay.
and
slowly on the opposite side also. Okay.
Yes,
Now that you know that much part up to umbilicus has come down. Now
Yes.
what do we do?
Now we will hold the pelvic. We will hold the pelvic.
Okay.
Yeah,
Okay. Like this. Okay.
Yes, and we have hold it and with the fingers placed over the iliac crest and the thumbs placed over the sacrum. We will
Okay.
sway the trunk firstly towards 90 degrees and so that the...
Why we want to interfere here, my dear? Let the mother push the baby down.
Yeah,
Let it
the
go
mother,
up to
we
the
will always...
scapula.
Yes, ma'am, we will always encourage the mother to push down.
Never. See, there are no two don'ts. Never turn the baby. Okay, that is one. Never give any traction. That is the second message here. Okay, let the
Yes.
baby deliver on its own up to the scapulae at least. Okay, and
Yes.
then you try to try to deliver the hands. Now, how will you deliver the hands?
Ma'am, the delivery of the hands, if the back is anterior, if the back is anterior, then the scapula is visible. The trunk is rotated in such a way that the anterior shoulder and arm appears at the vulva and can easily be delivered. And then the body of the fetus is rotated in reverse direction to deliver the other shoulder and arms.
What is meant, what Madam Dr. Sneha was asking about assisted delivery. What you are telling is the extraction for extended arms.
Yes, ma'am.
By the time Madam reconnects, I would just like to comment on a...
I'm here. I'm here. No worries. So,
Yes.
so you know this. We are conducting assisted breech delivery. The babies. That's the reason I'm saying that sometimes you plan for taking her for cesarean section, but the baby, you know, the mother pushes out the fetus and the breech comes down. Then of course you have no option but to conduct the assisted breech delivery. So if up to the scapulae the baby has come out, now it's your duty to extract the upper limb. Okay, so how do you do that? And then how do you deliver the head? Come on, last two steps now.
Ma'am, if it is coming spontaneously, then we'll just gently, after the axilla is visible, we can just gently deliver the hand with the help of our hands. We can gently deliver it.
Correct.
Then the shoulder will be delivered, and after that, we can the aftercoming head of the breech will be delivered.
How?
Ma'am, we will. With the help of Marise maneuver.
Yeah, Mauritius maneuver.
Yeah, Marise maneuver. Yes, ma'am. We will put index finger and the middle finger over the maxilla of the fetus, and the fetus body is allowed to rest on the palm.
This maneuver, or you will just see that whether it is spontaneously delivered. Sometimes the baby just the head just delivers by extension. Okay.
Yeah.
And then, yeah, if not, then what do you do? What is that maneuver?
And we will place the index finger and the middle finger over the maxilla of the fetus, and the fetus should be allowed to rest on the hand and the forehead.
What is the simplest maneuver? The Burns-Marshall technique. Okay, the Burns-Marshall technique. You have the baby in your hand. Your hands are like this on the pelvis, and you have delivered everything. Now what you do is put catch hold of the ankles. Okay, you're supporting the baby like this. Just rotate the baby on the mother's abdomen with a long arch. Okay, so just by extension of the fetal head, the baby is delivered. That is the simplest one, which usually happens. Okay, if it doesn't happen, then you have to go for Mauritius maneuver. So how do you do that? Where is your left hand? Which finger where? Where is the right hand?
The left hand index finger and the middle finger should be over the maxilla of the baby, and the baby is allowed to rest over the hands and the forearm.
Left forearm, right?
Yes, ma'am. And the right, the right index finger and the middle finger should be over the fetal head, the nape of the neck.
Both
And
okay, the middle finger on the occiput.
Yeah, the middle finger on the occiput and on the nape of the neck.
Yeah.
Then the assistant should be asked for suprapubic pressure, and with gentle traction, the delivery is achieved.
Yes. If not, then you of course have the forceps for the aftercoming head, and for this usually the Piper's forceps are preferred, right?
Yes.
Yeah. So I think this much is sufficient for the assisted breech delivery or breech delivery, because even today you can get this as a surprise and you shouldn't be panic, and at least you should be prepared to face this situation, right? So we go to Dr. Pramodita Singh now. Do we have Dr. Pramodita here?
Yes, ma'am.
Yeah. So good evening, Dr. Pramodita.
Good evening, ma'am.
34-year-old second gravida, the gestational diabetes. Gestational we are labeling because she is diagnosed as diabetic for the first time. We're not sure whether she was diabetic before the pregnancy. So she comes to you at 37 weeks of pregnancy. When you examine, you find 36 weeks cephalic presentation. The head is 3/5 palpable. Fetal heart is good. Cervix is 2 centimeter and fully effaced. Her labor progresses normally, and she's a second gravida. I told you, first normal vaginal delivery. And within 6 hours, she progresses very well. But after 20 minutes of full dilatation, the head is delivered, but the shoulders are stuck. What is your diagnosis, and how will you manage, Dr. Pramodita?
Diagnosis is obvious to all. It is a case of shoulder dystocia. In this case, maybe you told that patient is gestational diabetes, so maybe that is a predisposing factor for shoulder dystocia.
Yes.
And in this case, everything is okay till the delivery of fetal head. Problem starts from the shoulders. So we have to be quick, because fetal morbidity and mortality is very high in cases of shoulder dystocia. But at the same time, we have to manage some principles for delivering the fetal shoulders. Principles being, we have to call for extra help because we need assistant. So we have to call for a staff, a pediatrician, and anesthetic in our labor room. Meanwhile, we have to resuscitate baby also, clear the nose and mouth, give a liberal episiotomy if not given.
We are stuck on the shoulders. We are stuck on the shoulders. How do we deliver?
Nose and mouth are there, na? So we can clean this thing. And ma'am, then stop doing tractions over fetal hand and giving fundal pressure, because it will increase the pressure impaction of the fetal shoulders in the maternal pelvis. Then there are some maneuvers we have to follow, but our guidelines, ACOG guidelines, say no one is better than no one is superior than any other. But when we have to follow, there are some first one, which one is follow.
Some do's and don'ts which you should follow.
Yes, do's में आपको extra help रखनी है, clear nose and clear करना है, episiotomy देना है. Don'ts में we don't have to push fetal head and don't give fundal pressure. Because and then we start. Don't panic, but we have to be a little bit faster, because morbidity and mortality at the same time both should be go simultaneous. Then there are some maneuvers we have to follow. First one is grasp the fetal head and neck and give traction posteriorly. Meanwhile, one assistant give a suprapubic pressure. This will decrease the base acromial diameter and rotate the anterior shoulder of fetus to the oblique diameter. This will help to extract the fetal shoulder. This maneuver is you can say most easy and easiest.
But I would say, what about this will work only when the mother has an extra space. So how do you do that?
If this maneuver fails, we go to the second maneuver, that is called Mac-Roberts maneuver. In this, we have to abduct the maternal thighs.
Yeah, but I would suggest Mac-Roberts should be the first, because that is the simplest. You have to just do hyperflexion of the mother's lower extremity, legs of the abdomen,
abduct the thigh and sharply hyperflex the maternal legs onto the abdomen. And meanwhile, we have to give suprapubic pressure. This will what this will do. This will upward shift the pubic symphysis and decreases the pelvic inclination angle, and flattens the lumbosacral angle. This will increase the anterior posterior diameter. This procedure is very effective, 90%, more than 90% effective, as the book. And as till in our practice, we have to most of the patient we remove the shoulders by doing Mac Roberts maneuver.
So now I ask you, just for everybody's knowledge, where do you give the suprapubic pressure? Mother's right, left? How do you decide where to give the? Because that is a very deciding point. So where do you give the suprapubic pressure?
Ma'am, a little bit towards with the fetal head side. The fetal head is more on that side.
You are closer to that, but see what you can see, not on the fetal head. Fetal head will be as a globe, no, everywhere. You can see what I'm trying to say. The side of the occiput, because you can see the head which is already outside.
So purpose is here. Our purpose to sorry, excuse me.
Madam, I will ask you to comment.
No, is already you are doing it. It's okay. Thank you.
Yeah, so the only I will have your expert comment. Only point here is that if you see the occiput, that side shoulder, you have to give the suprapubic pressure, because that is one is stuck. So, Madam Jaswar, your comments, please.
So already here we have to do two procedure. One, to increase the pelvic cavity, which is by the hyperflexion of the limb.
Yes.
One thing. Second thing, at the same time, we have to reduce the biacromial diameter of the fetus. So in this, we have to push the anterior shoulder towards the ventral aspect of the baby. So we can take where is the back, where is the face of the baby. So towards the face it should be. So ultimately it will come into the one of the oblique, and so it will come out. That is the purpose, to increase the pelvic diameter and reduce the biacromial diameter. So these procedures should be done together, not by one.
Yes.
Yes.
So that is what the message is, Dr. Akshit. The Mac Roberts maneuver and suprapubic pressure, these are not two different. In fact, they are complementary to each other. Sorry. And this is the diagram which is explaining what Madam has said, that how it increases that pelvic diameter, and how that you can see that shoulder actually being compressed by the sister or your assistant, the shoulder getting pushed toward the ventral aspect of the baby, reducing the
bisacopial diameter. Yeah, very right, ma'am. Very right.
Madam has explained it, and this is a very self-explanatory diagram which is for all of you. Okay. Now, suppose it doesn't work, then what will you do, and how will you do?
Then ma'am, what's corkscrew maneuver, as you slide you have shown, in this general anesthesia is this general anesthesia is needed. General anesthesia is given to the patient. A 2-finger is posed inside the vagina, and the posterior shoulder is rotated 180 degree in corkscrew maneuver to anterior. This will allow the bisacromial.
Why do you do this? That is what I'm trying to ask you.
Ma'am, bisacromial diameter, so that come into the pelvic inlet in the oblique diameter. Then we put 2 fingers in the vagina from behind the posterior humerus of the baby, and put the fingers onto the baby chest, and giving a little bit traction, and suprapubic pressure is also given by simultaneously by the assistant, and with a slight traction we disimpact the baby from the pelvis. But this will create more injury to the baby, clavicle fracture and all.
So what you have explained technically, but here I can show you that, why you do that. You can see the anterior shoulder is the one which is impacted, right? So posterior has already escaped down. So why rotate it 180? Now the anterior becomes posterior. So that also escapes down. Okay?
Yes.
It is the impacted shoulder which escapes down by this maneuver. Okay?
Yes.
Because the posterior one is already at a lower layer, it has already escaped, and this one which is impacted, now that will also escape with this maneuver. So of course, what we have discussed, the do's and don'ts. So the message very well given right at the beginning, not to become panic, but you have to be swift, quick, and you have to call for help and be prepared with all the manners. What we have helper and all these protocols and numericals. Yeah.
One more thing, no? As the patient's attendant should be informed that we are stuck in this condition and we are going to do this procedures, and this will be the complications at the same time for the preventing the litigations also in present scenario.
First and foremost precaution or the caution for such patients is shoulder dystocia is a condition which is totally unpredictable. Not only
Yes,
the
ma'am.
macrosomic baby or large babies land up into shoulder dystocia, even the average size babies can land up into shoulder dystocia. That is what the evidence says, and that is for your safety. So you have to talk to the patient and relatives. Okay? So of course you have to be transparent with the patient and be communicative with the patient and relatives. You have to make them witness that you are trying your best, and of course you have to explain them from time to time. That is what the whole thing is. But then you have to concentrate on the management and deliver the baby at the earliest. So thank you for the wonderful discussion, and thank you, Madam S.P. Jaiswal, for your inputs, very valuable. We now go to the last case. I think this is actually the partogram, so I skipped this. Sir has taken it very in depth, and also the newer aspects of WHO labor care guide. So the last case, Dr. Priyanka is not here, but I think we just go ahead quickly. Second gravida, previous seizure for fetal distress, presented with labor pains. Contractions, 2 to 3 contractions in 10 minutes, lasting for 30 to 40 seconds. No scar tenderness. Cervix is 6 centimeter, fully effaced. Your vertex gestation 0. Full dilatation. There is severe bradycardia. Okay, so vertex is +1. There is bleeding, which is not show more than average. No contractions. When you catheterize the bladder, there is blood tinged urine. So what is your diagnosis? Very obvious, but yes, you need to discuss this.
Ma'am, Dr. Manju Gupta has not participated. She can take this question.
Yes. Whosoever has not participated. In fact, I can't see all of them. Madam, Dr. Manju Gupta, please. Dr. Manju Gupta, can we have from your side? No, if she's not active, then how we can involve her?
Otherwise, we have other presidents also, Dr. Kavita Nagar and all. If you can, any one of you can take the question, please. Dr. Ekika Kavita Nagar, any one of you?
We have Dr. Ekika Singh. I don't think they are there. Okay.
Yes.
Can I take the question?
This is a case of, yes.
Okay, Lalita, go ahead, please.
Ma'am, this is obviously diagnosed, we can say, uterine rupture case. Because as we see in the question, the fetal, the sign of the impending rupture are the presenting part is going high up, and the fetal bradycardia is there, and the patient is somehow complaining of bleeding, and patient is in shock. So we can
yeah, the only message from this case is that it's not necessary that the patient should have very severe contraction and they disappear. It's not necessary or mandatory that the patient should have scar tenderness, and it's not necessary that till the end of maybe the baby's head is not descending down. So everything can go in line what you are expecting. In spite of this, the patient can land up into uterine rupture. So you have to be very cautious. You have to see that whether she is high risk for this uterine rupture. So definitely uterine scar thickness or myometrial thickness, term during labor, and of course your clinical judgment. But here there is no scar tenderness, so your judgment has not helped. But definitely when you have a patient of previous seizure, you have to anticipate. You have to anticipate, keep the index of suspicion very high, and you have to have a skilled supervision, prompt detection, effective institution of the therapy, and you have to avoid the disastrous consequences. So definitely not to forget with good communication with the patient and relatives. And of course, in spite of good communication, keep on documenting whatever
Yes.
you have done best of your capacity. So that is
Yes.
what the message is.
Thank you.
I'm sure all of you, all the delegates have been benefited for the discussion. I would like to thank all the esteemed panelists for their wonderful discussion, their valuable inputs, and I'm sure it has helped everybody. I thank UPCOG, especially Madam Kirti Dubey, and President Madam Kirti Dubey and Secretary Dr. Bharti Maheshwari, and of course the entire team office bearers of UPCOG. I thank all the four president societies. Dr. Nutan, I think please mute yourself. The president and secretaries of all the president and secretaries of all the four societies, that Mujaffar, Nagar, Meerut, Mau, and Saharanpur. I thank Madam SP Jaiswal for her wonderful inputs, and of course the last minute.
Thank you, Dr. Sneha. Thank you so much.
Thank you so much, madam.
Thank you.
It was pleasure to have you, and thank you everyone. I just make an humble appeal to all of you that I'm contesting for Vice President Foxy from West Zone.
ये क्या आ गई रास्ते से भाई?
I need your support, wholehearted
Yeah.
support. I request all the presidents and secretaries from all the societies of UPCOG to please nominate me, and all of you members of Foxy to please vote for me in the coming election. Thank you so much. I hope we have done justice to our discussion and lots of take-home messages. As Dr. Malhotras have said that, labor, delivery, people are forgetting, the labor is or conducting delivery is a forgotten art, after a few days, maybe few years, you have to say this, but we will not let it happen and we will continue our efforts. Thank you so much. Over to you, Dr. Nutan.
Thank you.
I think you need to unmute now. Okay.
Yes. Thank you so much, Jaiswal ma'am. Is she there or she has logged out?
Yeah. Just for official vote of thanks.
Yes.
Yeah.
Thank you so much, ma'am. Thank each and every president and secretaries for joining and giving their full cooperation. Thank all the experts who have joined and given their valuable inputs. Thank you, Sneha ma'am, and we wish you all the best for your candidature, and we hope that you are going to come out with flying colors. Lots of wishes. I can see Akika finally. Akika.
Yeah, I'm sorry, Dr. Nutan. That time my net was not working when Dr. Sneha asked. I am so sorry.
Hi, Dr. Akika.
Hi,
Yes,
Dr.
yes.
Sneha. It's doing so nice and it was really very clinical. And I'm so happy that all the participants had really good, very nice input, and the way you have, taken the session in such a clinical way. It's so nice to be here. Ma'am, one thing for scar thickness, I just wanted to say, scar thickness, if it's during antepartum, it is somewhere between 4 millimeter or something, we have to be cautious.
Yeah.
For if we are taking a trial of delivery. And that's it. And ma'am, once again, wish you all the best for the elections, and you'll have all our supports. And I want to thank all my seniors and mentors from the UPCOG team who are always there for us. And thank you, Dr. Nutan, for letting us participate, and especially my panelists from my society, Dr. Pramodita and Dr. Anisha. They did well.
Yeah.
And thank you very much, ma'am. Thank you very much.
Thanks, dear Akika. Thank you so much.
Thank you everyone, and yes, it's
looking
been a
forward to
pleasure
meeting you all
hosting this
sometime
webinar.
physically as well. Yes.
And I think we had slight glitches of net connection, but this is how things move on and take it to the right thing. Hope to see all of you very soon. Now, I will just like to add, Sneha madam is going to be connected to UPCOG. We are going to have 3 more webinars in with 4 different societies,
Yeah.
but we'll
After
keep
15
sharing.
days, the second
Yes.
session with different societies.
Every alternate Wednesday, this is going to continue, and I'll be sharing the links to all the presidents whom we have connected. You are all welcome, invited. please keep joining in and let's keep learning and enriching ourselves. And wishes once again to everyone. Hope to keep meeting each other soon. Thank you.
Bye-bye.
Thank you. Thank you
and
once again.
wishes
Thank
once
you.
again.
Thanks,
Okay.
Thank you. Bye-bye.
Good night, everyone. Thank you. Thank you
Good
so
night.
much. Thank you. Thank you.
Thank you, ma'am.